Hello, Dave.
Hey Namdi, how are you?
Good.
Good.
Okay.
Let me switch my audio real quick.
Okay. So, are you able to launch the poll?
I need
Yeah.
screen sharing. I need
Yeah.
screen
Okay.
sharing.
And then I'll need to also make you a co-host so that you can launch the poll yourself.
Yeah, I think I'm gonna probably not use the polls.
Oh, okay. Okay.
Okay, let me try to. Can you see it okay?
Yeah.
Okay, 1 second here. Just want to. All right, what do you see? Do you see full screen?
Yeah.
Okay. I am just gonna go get a cup of tea.
Okay.
So I will be back in just a few minutes.
All right. Sounds good.
Hello, Kristen.
Hello, David. How are you?
I'm well.
Good.
And Namdi, I'm fine making self-introductions, so don't feel like you need to
Okay.
go over bio or anything like that. We'll just dive right in.
Well, I could just introduce you briefly.
Yeah, that's fine.
Yeah. How are you, Kristen?
Sorry, I muted myself and then my controls disappear. So then I have to, I'm well, thanks.
Great.
I was thinking we may need to wait a couple of minutes past the hour. Just because like last time people probably will click the link and then have to register.
Okay.
Yeah, I see Darren joined. How are you, Darren?
I'm hanging in there, and forgive me, I was eating some lunch with my mouth full, so that's why I had my camera off. But I'm really excited to listen
Yeah,
um to your talk, and it's good to see you, Dave.
you too. You too. Hopefully you're going to be enjoying some winter activities here shortly.
Much like you, I hope.
Yes. Oh, I can
Although
ride.
I'm heading to the desert for Thanksgiving break to mountain bike some, so I hope it staves off just a little longer.
Good, good. Well, I'm pretty comfortable riding on the road year round, just as long as it's above like 25. So, but I think going someplace warmer is typically smarter. So kudos to
You're tougher than me too, Dave.
I doubt that. Knowing your track record. Well, I will let you eat. Don't let me interrupt you. We'll give it a couple more minutes, Namdi. Okay. Namdi, if you want to open it up here, we'll get started and people can join.
All right. Good afternoon, and thanks everyone. Thank you very much for joining us for today's Grand Rounds on vaccines updates. My name is Namdi Moiteke. I'm the project coordinator of the Idaho Collaborative for Infectious Disease Prevention and the moderator for today's event. Just a friendly reminder that we should all stay muted, except when we have the floor. And then we would like this meeting to be as engaging and interactive as possible. So at the end of the presentation, we'll encourage everyone to make contributions and give comments, ask questions using the chats or the Q&A function of the Zoom meeting, or using the raise hand function of Zoom. Please, there will also be a survey at the end of the meeting, an anonymous survey appearing on your browser, and kindly complete the brief survey to help us evaluate events. So our speaker today is Dr. Dave Hashi, who is a professor in the Department of Family Medicine and the Ryan White HIV Program Director at Idaho State University. And Dr. Hashi is also a co-principal investigator of the Idaho Collaborative for Infectious Disease Prevention. And his interests in vaccines and preventable diseases is rooted in 25 years of teaching, clinical practice, and scholarship at local and regional and global levels. And so he will be highlighting recent changes to the guidelines for common vaccines, including those for influenza and pneumonia, RSV, measles, and COVID-19. So over to you, Dave.
Super. Thank you, Namdi. And I know that we have some people sort of still creeping in, but we have a small group. So I'd like to keep this as informal as possible. So if you do have a question, feel free to unmute and we can have some good dialogue. If you want to put something in the meeting chat, I have that up. I'll try to be monitoring that as well. So as Nandi said, I'm a pharmacist by training. I work in lots of environments, the classroom, the clinic, as well as the community pharmacies, where I talk to people about vaccines on a regular basis, using shared decision making, provide education and support, and also at times still administering vaccines. So let's kind of dive into it. And as Nandi said, I want to highlight some of the recent changes as there's been a lot of movement with the common vaccines. There's plenty of other vaccines out there other than these, 7 or 8 that we're going to kind of walk through. And at the end, I do have one last slide going over some of the other vaccines as honorable mentions, but certainly no less important than the ones that we are going to be talking about. There's just been, I think, less attention and less changes. And just a quick disclosure slide. A lot of the information that I'm providing, I just like my audience to know where I'm getting it, and the majority is coming from the CDC. If you've been in touch with what's been happening at the federal level, there's been a lot of movement at the CDC, changes in funding both on a national and global landscape, which has changed the CDC's ability to function in some capacity, but they still have excellent resources both for clinicians and patients. I will pull information from other locations, and I'll note that in the slides. And when we talk about COVID, I'll be highlighting things such as the American Academy of Pediatrics, American College of Obstetrics and Gynecology, as with some of the changes at the federal level. Other institutions, organization have taken the lead to promote a lot of their evidence-based recommendations. And there are other coalitions being formed in the wake of changes at the federal level, including which you may have heard about, the West Coast Health Alliance, which right now includes California, Hawaii, Oregon, and Washington, and then the Northeast Public Health Collaborative. And so I've done my best to update this information as of yesterday. I certainly may have missed something, and if I have, I do encourage you to chime in and redirect or correct any content that you may have questions with. Let's start with something that really can't be all that confrontational, and that's influenza. And influenza vaccine has been around forever and a day, and it's probably the most simple and straightforward. But I think just as a background to talk about why this is so important is that we still see tens of thousands of deaths annually from influenza. The latest count in children is 280, and these were mostly healthy children who were less than 9. So and these children were mostly unvaccinated. So again, we're talking about vaccine preventable illness and disease, which not only affects morbidity and mortality, but as you can see here, the burden it places on the healthcare system with medical visits, hospitalizations, is immense. And the 2005 recommendation hasn't changed from previous years. Essentially, if you have a pulse, you're greater than 6 months old, no contraindications, you should be vaccinated for influenza. The vaccine efficacy is moderate at best, but is still substantial enough to warrant, again, the benefits outweighing any risks of the vaccine. So it has about a 50% efficacy in reducing outpatient hospital visits and roughly 50 to 70% in reducing hospitalizations for adults and children. Now, this fluctuates from year to year based on how accurate the researchers were in predicting the strain that's coming over. And so you will see these numbers fluctuate from year to year, as well as in different age groups. And speaking of age groups, there is that cutoff that those individuals 65 and above who may have less of an ability to mount an immune response should receive the high dose vaccine. And if you or your patients are over 65, do inquire with the location that they're getting the vaccine to make sure it is the appropriate one. If Inventory's out, stock shortages. It is fine to get the non-high dose, but if you can get in there early enough to get the high dose, that's great. The FluMist, which is the non-injection influenza vaccine, and it's a live vaccine. This one's administered intranasal. It's typically been very favorable for kids or individuals who have a phobia of needles. And this one is also now available at home. If you go to FluMist website, you may be able to enter information to receive an at-home FluMist. And there are some restrictions around the age. It's, I believe, 2 to 49, should not be used in individuals who are pregnant or immunosuppressed. And speaking of individuals who are pregnant, is recommended to receive the inactivated influenza trivalent or the recombinant influenza vaccine. And there has also been some movement in regards to patients that have a history of egg allergies, as many vaccines may be formulated with eggs. There was the precaution to avoid vaccine if you have an egg allergy. That is no longer the case. And when we talk about the best window, we're sort of in that window of October, November. If we vaccinate earlier than that, we may see titers wane over time and have less protection later in the season. And if we do it too late, we may miss that early rise that we're actually beginning to see, as we'll take a look at here on the next couple of slides. And the other piece of data that's emerging that I find very exciting is the fact that these vaccines are reducing cardiovascular and cerebrovascular events in certain groups. And the flu vaccine, in looking from some of this literature, has been shown to reduce rates of myocardial infarctions by 25%. So essentially, what that translates to is essentially needing to vaccinate 56 patients to reduce the rate of 1 MI. And when we talk about the millions of vaccine doses, this can be pretty significant. So this is fairly early data, observational. But when we look at other vaccines such as shingles and other conditions, I think we're going to be seeing more of this data emerge, given the link of infections and inflammation and what that may translate to. So again, really quite exciting. This was the situation of influenza about 6 weeks ago, a week ending in October 4th. So essentially no influenza activity. And at the end of the week, about a week and a half ago, what we started seeing is a lot of activity in the southeast as well as the west. And I imagine we would start seeing rises in cases here in Idaho as well here shortly. So that's influenza. Again, not a ton of changes, but important to talk patients through the importance of the vaccine, navigate any vaccine hesitancy with good supportive dialogue, and kind of meet patients where they're at. We're going to shift over to pneumonia and the pneumococcal vaccine. And again, when we talk about pneumococcus and we talk about the bacteria, strep pneumo, we're talking about bacteria that can cause what we think of a lot of times as lung infection or pneumonia, but is also responsible for meningitis, bacteremia, otitis media in children, and sinusitis. And anyone can get pneumococcal disease, but those with cardiovascular disease, pre-existing lung disease, individuals like that may be at higher or increased risks. And keeping up with these recommendations is the best way to, again, prevent pneumococcal disease. And so where are we in 2025? There have been some changes in availability. The available vaccines that are out there come in two formulations. The older one that many of us remember from years ago, which is the pneumococcal polysaccharide vaccine. That was Pneumovax 23. And that was a standard for a long time, but it was one of those vaccines that people needed multiple doses, some before 65, then after 65, spreading out over 5 years, and it became really confusing. Then with the introduction of the conjugate vaccine, the PCV vaccine, we have seen now a broader coverage in serotypes. And the vaccine recommendation for children hasn't changed in context of the number of doses. It's still a 4-dose series, but now we're looking at using a 20-valent vaccine, so something that covers more strains. We also recommend a single dose in individuals 5 through 49 with certain risk conditions that I already highlighted. And then for individuals 50 and older, it's recommended administering the 20 or 21 valent one time for all individuals 50 and older. So although we have come from an environment where it's been confusing of having two different ones and using them both, it's now becoming a bit simpler. With the introduction of these newer conjugate vaccines, which tend to mount a more robust immune response, what we're seeing is one time and you're good for life. So when we look at those individuals 50 and above, it's recommended everybody receive a pneumonia vaccine. If they get the PCV 20 or 21, you get it one time, you're good for life. For individuals who have been vaccinated several years ago and may have received the 13-valent or the 23-valent polysaccharide vaccine, as long as 1 year has elapsed, then you can give the 20 or 21 valent and then they're done for life. Those over 65 who have previously had that series with the 23 valent, wait 5 years, and then they can get 1 dose and they're again done. And I think having that shared decision making of if they can't remember if they've had it or how many years, the benefits typically outweigh the risks. The timing in why we generally wait is that if you give the vaccine too early, you may not see as much of a immune response. You'll still see some, but maybe not as much if you wait the appropriate time. So trying to get accurate records, having some supportive shared decision making to help patients can get the best coverage that they can. Now, RSV. This is the respiratory syncytial virus has gained more, I think, popularity, notoriety, whatever language you want to use over the last few years. It's been, I remember, seeing in the news the triple-demic of COVID, flu, and RSV. Is that the reality with RSV is that, again, it's really common, causes mild cold-like symptoms, but the most vulnerable populations are the really young and the really old. And that's where we're really focusing vaccine advocacy and use for. And so the CDC at this point currently recommends immunizations to protect young infants, some young adults, and those older adults with certain risk factors for severe RSV. And right now it's a single dose of one of 3 FDA licensed vaccines. And that age cutoff, again, is 75 and older. Perfectly fine to request any RSV vaccine. If you're between 50 and 74, a lot of times having the conversation with either the pharmacist or your healthcare provider of whether or not you have the conditions that meet that. And there's a whole list of them: cardiovascular disease, lung disease, renal disease, diabetes, neurologic, neuromuscular disease, chronic liver disease. There's just a lot of them. So if you have any chronic health conditions, chances are you would be eligible for this. The two vaccines that have been out for several years are GSK's and Pfizer's, the Arexvy and the Abrysvo, and the new one this year is Moderna's. And we'll see that there are some inherent differences between those. And as far as recommending, this is the best time of year, again, late summer, early fall, before RSV season. And we'll look at some specific windows with when we talk about kids here in a little bit. Pregnancy is an opportune time and a recommended time to vaccinate, so that the mom can develop antibodies and then pass them on to the newborn, so that the newborn has those antibodies through RSV season. And the recommended window is late in pregnancy, so 32 through roughly 37 weeks. In that September through January window, when the baby would be born into RSV season. The mom should receive 1 dose of Abrysvo, and that has been shown to reduce newborn hospitalizations nearly 70%. And if we're unable to vaccinate the mom, or the mom does not want the vaccine, or the vaccine is not available, then there are options for the kids. And the kids' options are not a vaccine. The kids are a monoclonal antibodies. And these monoclonal antibodies provide passive immunity, and they are extremely effective, reducing hospitalization from RSV by nearly 80%. And so when we look at those children, I'm just going to go to the next slide here because I'm more of a visual learner. So children born in RSV season between October and March, whose mother did not receive the vaccine, can receive 1 dose of nirsevimab or clesrovimab. Those are anytime you see a medication that says MAB, that's a monoclonal antibody, and that will, in this case, help reduce the likelihood of infection if the infant is exposed. This is the dosing for moms, and then for older individuals, again 75 and above, or that I believe it's now 50 to 74 for those high dose or those high risk individuals. So the questions around RSV right now, and some that were raised recently at the federal level with the Advisory Committee on Immunization Practices, were some safety concerns. As with all vaccines, there are risks. They are considered medications. They go through the approval process like other medications to be approved by the FDA. And there was a small increase of Guillain-Barré syndrome within 42 days, seen with both GSK's and Pfizer's vaccines. This has not been identified with Moderna's. So if patients do have risk or have had a history of Guillain-Barré but still want this vaccine, it would be recommended probably to use Moderna's vaccine. The number of doses is still to be determined. Right now, it's not annual. And after receiving it once, we don't have any good guidance. Research is ongoing looking at titer coverage as well as hospitalizations, and if there's a threshold for which individuals may be eligible for another dose. And it is fine to administer with other vaccines. There were some, I think, initial concerns, but it is not a live vaccine, and it is fine to co-administer. And so some of the conversation that came up in the recent meeting at the federal level is, what do we do with individuals younger than 50 years? And because there are no recommendations, the current situation is to get more research, and get more information on the benefit of the vaccine in individuals less than 50. Want to look at those signals for Guillain-Barré syndrome. We want to look at the duration of protection of these vaccines. So that may take several years to get that data. We want to look at individuals who are immunocompromised and get more data on the cost effectiveness of the vaccine. And once the ACIP and the CDC has more information on that, then I think we'll see stronger recommendations. Okay. And remember, if you have any questions, especially if there are some of you that came in a little bit later, feel free to unmute. We have a fairly small group, or put your questions or comments in the chat. COVID-19. This obviously month and a half ago had quite a bit more buzz and concern and issues around it. We're starting to come out the other side, I think. But just to put this in context for everybody, the reminder of why we vaccinate. Why we vaccinate is to prevent serious health outcomes, not to prevent individuals from actually getting the infection. But when individuals do get infected and they have the vaccine on board, there's less likelihood for hospitalizations and death. So clinical trials, real-world studies consistently show the vaccines provide sustained and reliable protection against severe illness and death, even with new variants. And again, I find this statement, although simple and profound, there is still a strong vaccine hesitancy notion out there that these vaccines are not studied and not approved, and that's not true. So sharing that information with individuals and patients that may bring that up when they have that concern, getting more information from them and providing that information that these medications would not be available on shelves were they not at least had some expanded use authorization through the FDA or full FDA approval. Now, again, retrospect, some things that I think we lose sight of is the number of deaths that we have seen from COVID, and the fact that a majority of us probably on this call have lost somebody to COVID or know somebody that has had some severe complications. And when we look through 2021, 22, we see high spikes. And then with the introduction of the vaccine in 21 and broader use in 22, we have seen a reduction in deaths subsequently every year. And cumulatively, we have seen nearly 1.2, 1.3 million deaths in the US. And the nice thing is that from year to year, we are seeing a decrease in number of deaths. So the heavy blue line is the 2022-23 year, red is 23-24, and light blue is 24-25. The interesting thing with COVID is it doesn't follow the seasonal pattern that we see with something like influenza, but we have over the last few years seen sort of this bimodal distribution that in December, January, we certainly can see a spike, and then through spring and early summer, it drops, and then late summer, we do see another bump, and then again, kind of through the holidays now, mass gatherings, somebody has COVID, it's still easy to pass around. So with that, we are seeing a reduction, and this is as again, a lot of people lose perspective, this is generally a result of vaccine efficacy. Reduction in this is hospitalizations, and with broader vaccine use, we will generally see fewer vaccine or fewer hospitalizations. So over the last couple months, there's been a lot of confusions for patients, providers, manufacturers, insurance, and pharmacies. And so just to line everybody up, it's the FDA who's responsible for evaluating the drug companies' proposals to bring a drug to market, in this case, bring a vaccine. The FDA reviews and will either approve or deny a drug or vaccine based on data, or even limit its use. And although previous FDA approvals has seen broader range of COVID vaccines, it's now moved to a more restricted range. Follow that up, then the ACIP, or the Advisory Committee on Immunization Practices. This is the group that, if you recall, of about 17 members, was relieved of their duties by the current administration and replaced with 17 new members. And those individuals serve at the behest of the Secretary of the HHS, and they review information and provide guidance to the CDC, who generally always enacts the recommendations from the ACIP. Because there has been a shift in alignment of these three organizations, and there has been less reliance on some evidence, we have seen less trust in this process. And therefore, we have seen the emergence of other organizations, such as those coalitions, such as some of the governing bodies, American Academy of Pediatrics, gynecology, even state and local health departments utilizing their own guidance in instances that there may be less clear or more restrictive guidance at the federal level. So what do we have now? So the FDA approval range based on the package inserts are for individuals over 65. But we know that these medications have been studied down into pediatrics, and that the Moderna and Pfizer, the first two that were put out there, are based on the mRNA platform, as compared to the Novavax, which is a traditional protein base. It was later to come to market, but all three of them are FDA approved. And individuals who may not want to receive an mRNA vaccine for concerns or hesitancies based on information that they have heard, the Novavax platform is acceptable. And to some degree, some data suggests that antibody response may be a little bit more robust or long-lasting compared to some of the mRNA platforms. Regardless, if an individual, regardless of age down to the FDA-approved youngest age, has other conditions, that does make them, again, a strong candidate. And so you may recall about 2 months ago, there was a large meeting in Atlanta with the ACIP, which basically came out and said all COVID vaccine administration should be determined on individual decision-making. So shared decision-making between a patient and a provider, a patient and a pharmacist, and that applies to all individuals 6 months and older. So despite the fact that, that 65 and older gets the most bang for their buck, anybody who wants a COVID vaccine should still be able to walk into the pharmacy and request one and receive it. Some states also were requiring a prescription, and I don't know if that's changed much, but Idaho did not necessarily have that. We have a fairly broad pharmacist sort of prescriptive authority and vaccine administration authority, so that did not apply to us. But the ACIP voted not to have the requirement of a prescription, which is, again, helping to improve access. Then the other question that was getting raised is, will it be covered on insurance? And everything to my knowledge is that these vaccines are getting covered on insurance and are should be available at no cost through the end of 2026. Certainly, this is a moving target. We may see some changes here in the next vaccine season, but again, that is certainly some questions. Now, this is just a slide. I'm not gonna read it, but the bottom line is when the federal government was coming out with a more restrictive stance on the use of vaccines, not encouraging women who are pregnant to receive it, not encouraging children to receive it, the governing organizations in the U.S., the ACOG, American College of Obstetrics and Gynecology, and the AAP came out and said strongly that the data is clear that these vaccines are beneficial for these individuals, and especially with pregnancy, clinicians should provide strong recommendations to vaccinate pregnant and lactating mothers. And again, any parent wanting their child to receive a COVID vaccine should receive one. And the other side of the coin of the adverse effects, as with most vaccines, we're going to see soreness, pain, redness at the injection site. Patients may also get 24 to 48 hours of that joint pain, fever, chills, rarely nausea and vomiting. And then the concern that's raised is the myocarditis and pericarditis, and this is seen in typically young adolescent males within 7 days of their second COVID vaccine. And that certainly is a concern, and it's more seen from the mRNA platform. But the conversation, again, to let patients know is that the risk of myocarditis with being infected with COVID is 7 times higher than individuals that receive the vaccine. So you can still get myocarditis when you get COVID, and a lot of times it's going to be more severe. It's generally treatable. Symptoms last for a couple days. And if they want to avoid that risk, they can go with the protein-based platform of the Novavax formulation. So bringing this all together, I think for COVID, again, I think despite some of the difficulty in getting clear information, it really has not created a ton of barriers at the community level. But I think one thing it has done with all this confusion, it's provided those individuals with a little bit of hesitancy to have a bit more hesitancy, to be like, oh, now there's so much information, conflicting information. Now I'm definitely not going to get it. So I think going back to the roots of some good patient education, good conversation, meeting patients where they are, will, again, go a long way for trust and advocacy. That shared decision making, again, anyone who wants to have one should be able to get one. No need for a prescription. Insurance still should be able to cover it. And again, there are 3 vaccine options. I know not every pharmacy carries the Novavax. That's less distributed. So if that's something you do want, I do recommend calling around to see if that is in stock or in inventory in certain pharmacies. All right. All right. So moving on to hepatitis B. Hepatitis B has gotten a little bit of press because in the meeting a couple months ago, they recommended that all women be tested for hepatitis B. But right now, the current recommendation is that all newborns receive a birth dose of hepatitis B. And they couldn't come up with any resolution on that. So they tabled that vote about this neonatal Hep B vaccine until the next meeting. Now that meeting is happening here in a couple weeks, and they have essentially a whole day dedicated. This is the second day, it's the Friday. So the meeting is on the 4th and the 5th. You can stream those meetings generally live. You can look for the links on YouTube. but I'll be hopefully attending on the second day, where they're going to be talking and discussing and debating the Hep B vaccine dose for kids. So again, what's the deal with Hep B? On the one side of the coin, the ACIP committee is raising some concerns and proposing the delay of this dose because they think that there is some links to neurological issues and heightened irritability in newborns. There's no evidence really to suggest this. It's more of a concern. There's also issues raised of lack of long-term data. And then in comparing it to other countries, some people are saying other countries delay the birth dose and they're fine. But those that oppose the delay are saying, well, if we disrupt this schedule, because here in the US, Hep B is included with lots of other vaccines, that may throw off vaccine schedules for kid and lead to overall lower vaccine rates. For newborns that may not be following up with pediatric care, it leaves those kids vulnerable to contracting hepatitis B. Also, many women are not screened for hepatitis B. So although the ACIP says all women should be screened, we know that there isn't great access for everyone. Women may show up to deliver without having prenatal care and without being screened for hepatitis B, and administering that dose at birth is critical and important. And then the other thing too is flooding people with confusion and inequity, and will create more sort of, again, distrust. And if we miss these opportunities that we've done so well at reducing and to some degree eliminating the risk of hepatitis B in newborns, if we don't vaccinate, then long-term healthcare costs of hepatitis B infection, including liver disease, cancer, all of that is much higher. So right now, what does it look like? First, all infants, again, at least for the next few weeks, should get a birth dose, usually within that first, again, couple hours of birth. All children and adolescents younger than 19 who have not been vaccinated should receive it. Again, this is a universal vaccine now. Any individual 19 to 59 unvaccinated or requesting it should receive it, and older individuals with risk factors for hepatitis B. So it used to be, do you have multiple sex partners? Do you inject drugs? Do you do this, that? And because of stigma and shame and people not sharing that, we just reduce those barriers. You're of this age, you should receive the vaccine. And what do we have available for kids? We have the standard Engerix B, which is a 3-dose, same with the Recombavax at time 0, 1 month, and then 6 months. And then Pediarix, again, Pediarix is a combination. And for adults, the one that I generally find myself recommending is Heplisave B. This is an adjuvated hepatitis B vaccine, approved probably about 6-7 years ago. It's 2 doses, and individuals have about a 90% seroconversion rate, 95 at 2 doses, because again, it's really hard remembering getting that 3rd dose. And a lot of people will delay that, stretch that out, may need to go back to restart the series. So yeah, Heplisave B is very common out there. Okay, shifting on to measles. Again, measles has been getting a lot of attention in the last year plus. It was declared eliminated in the US in 2000, but come 2026, we'll probably see that change. In the US, MMR coverage, measles, mumps, rubella, has now decreased below the 95% coverage target. And we're seeing it increasing not only in the US, but on a global scale. And as of November 12th, these are you can see the sort of the monthly distribution of measles cases in the U.S. And when we dive into this a little bit deeper, again, we're up to a little over 1,700 cases of measles across the U.S. And in the last month since I've given this presentation, we've gone from 3 cases up to 11 cases. Many of you out there in public health may have seen this. But again, providers are a bit more heightened. And why should we be so concerned in Idaho? Partly because we have the lowest vaccination rates of measles in the country at about 79%. And what we've seen on, again, a US level is that 1,700 cases, about 60, 70% have been in individuals under 19, with 25% being under age 5. And when you look at those that have been impacted, 92% of the cases are in individuals who are unvaccinated or unsure of their vaccination status, majority being unvaccinated. We have, again, seen 3 deaths, have seen several hundred hospitalizations, and again, majority of those are going to be younger individuals. Again, this is the data showing the low vaccination rates, with Idaho leading the way at the bottom with 79% coverage. And if you've been following a bit of the news, Canada has been, I think they're up to 4,000 or 5,000 cases. They have lost their status of eradication, and my understanding is the US will probably lose theirs in the next 1 to 2 months. So we'll be seeing that come across as well. So what can we do? The first thing is advocate for vaccines, educate about vaccines, support the policies, programs, school systems, whatever you can do to advocate at the state and local levels is the best that we can do. And in part because there really is there's no specific antiviral therapy. And so management is generally supportive. And unfortunately, there's been a lot of misinformation floating around in regards to vitamin A. And we know that vitamin A does not prevent the measles. It's not a substitute for vaccine. And matter of fact, there have been reports of vitamin A toxicity in individuals having excessive ingestion of vitamin A. So getting the vaccine is going to be the best way to reduce that risk. And the one thing that did come out of that meeting a couple months ago is the separation of MMRV. So measles, mumps, rubella, and varicella are all live vaccines. And we've combined them all into a single dose to make it easier for administration and uptake in vaccination rates. But there was concern raised on the increase in febrile seizures up to 10 days after the 4 vaccine combination when compared to giving MMR separate from varicella. So because of that, we are going to see, again, some challenges, some concerns, more hesitancy in getting any of the vaccines, yet alone all of them. And so that's going to be a change also in manufacturing. This takes a while to change the formulations, gets the drugs to offices, clinics, and pharmacies. But that is the other change that we have seen come from the recent recommendations at the federal level. All right, now one of the, I think this is the last vaccine we're going to cover, is really talking about pertussis. And Tdap, again, it's like Neapolitan ice cream. It all comes together. Tetanus, diphtheria, and acellular pertussis, whether it's kids on DTaP or adults Tdap. Um, uh, Again, we've really seen this increase in the last few years of pertussis, or whooping cough. It's contagious, and because of waning vaccination rates and under vaccinating, we've seen a more transmission. So currently, the CDC recommends vaccines for infants and children and adolescents, and then pregnant women. Those again, sort of your target audience. And then for adults who didn't receive one as an adolescent or an adult. So essentially, anybody can walk into a pharmacy and say, I'd like a Tdap vaccine, as it's been a while, or I don't know when I've had mine, and they should be able to get it. For individuals, I have had patients come in and say, I don't want, I just want to get my tetanus vaccine. It's been 10 years. That doesn't exist, at least from what I've seen. It's not available. It's not being manufactured. Everything's lumped into tetanus, diphtheria, and acellular pertussis that people are getting kind of, again, every 10 years or more frequently in pregnancy. And so again, why the change? The change is that, again, going back to the 20s and looking at our, kudos to our public health people out there that have tracked this data for decades, is with the introduction of vaccines, we essentially saw very few cases. And it hasn't been up until like the last 10, 15 years that we have seen this bump in cases upwards of 30 to 50,000. So to prevent that with kids, we have the 5-dose series and thank you, Ian. There's a TD vaccine. Not sure if you still carry it. Okay, thanks. So it's that 5-dose series, 2, 4, and 6 months, and then again 15 to 18 and 4 to 6 years. Adults getting one every 10 years after they've completed their series, and 1 dose of Tdap during each pregnancy, preferably earlier part. And then what we're also seeing is recommendation for individuals that may be around a newborn. So this may refer to the partner of the pregnant woman, or grandparents or immediate family members. A lot of times there's encouragement to be vaccinated. So just a few quick highlights. Haven't been a lot of changes, but again, HPV, and we have a lot of people at the state HPV sort of cervical cancer coalition. But it's not just cervical cancer that we're talking about. This is for pharyngeal cancer, rectal, anal cancer. So HPV can cause cancer in several places, but advocating for starting that vaccine for children between ages of 9 and 12 and completing the series as indicated. Hep A, again, is a focus typically on individuals experiencing homelessness. That is one of the most vulnerable populations. And again, for those of you out in public health land, also may experience these when you see outbreaks in foodborne or in daycares, and individuals need that vaccine for post-exposure prophylaxis in that 2-week window. We've seen, again, a bit from wastewater tracking, polio, rotavirus, again, some concerns with the adverse effects of intussusception. Those rates are extremely low. Varicella, as I mentioned, again, separating that from MMR. And then shingles, the data that's come out on shingles is, and I alluded to this earlier, we've seen about a 20% reduction in MIs and strokes, which is, again, thought to be related through inflammation of those nerves and And anytime we can reduce that likelihood, we can see a reduction in those disease. So really right now, it's everybody 50 and older. That's universal. And for individuals less than 50 who may become or are immunocompromised. And target populations we look at, for example, are people living with HIV, people on immunosuppressants, or individuals, let's say, are diagnosed with cancer. So let's say you have a 40-year-old diagnosed with breast cancer who's going to be undergoing chemotherapy or radiation, may become immunosuppressed, get that vaccine immediately. It's 2 doses times 0, then again at about 8 weeks. With some immunocompromised people, you can give it at 4 weeks, but at least getting that first dose on board is helpful. And there are lots of other vaccines out there we didn't cover. We could talk about certainly things like Mpox, travel vaccines, all those other ones. But really, this was just, I think, given everything that's been out there, and it's so hard to stay on top of, hopefully for those of you that are in this environment, this has provided you with, again, a little perspective on the different vaccines where we've seen a lot of movement, where there's been a lot of questions. And so with that, I will certainly open it up for some conversation, some dialogue, and get everybody to their 1 o'clock on time. So questions, thoughts?
Very much, Dave. We have a question in the Q&A. Can you see it?
Yes, I saw that one from Ian. Again, thank you, Ian. So do you, have you had it and have been able to administer just tetanus and diphtheria?
Yeah, we used to carry it routinely, but I haven't seen it in a while, but we may still have it. But I pretty much, if there's an option to give someone a Tdap vaccine, I would rather give them a Tdap vaccine. I mean, I think the immunity from the pertussis component wanes after less than 2 years. And so, and there's not any contraindication to administering Tdap instead of TD. And so basically, anytime someone comes through and is wanting a tetanus vaccine, we're giving them Tdap, and that's probably preferable to TD anyways, because the difference in risks between them is minimal, and the benefit for Tdap is superior, at least for community health. I have a question for you also, Dave, about if ACIP goes down the tubes, who are you going to listen to as for your vaccine advice? Do you got a independent organization that you think is trustworthy?
Yeah, that lines up with Rachel's question as well. Is again, what are these unintended consequences of different organizations coming out with their own guidance? Both of those are great questions, and let me first answer it by the evidence that despite the recommendations that are coming out, we have evidence that is existing that we have been making good, strong public health recommendations off of. That data just doesn't disappear or go away. What happens is individuals choose to selectively look at that certain data that supports their argument for or against the use of certain vaccines. And so I do fear, Rachel, that we are going to see a bit more confusion based on when the patients come and they say, I've heard this and that. And for providers, it's hard to stay on top of what patients are hearing and what they're seeing and where they're seeing it. So I will go to the CDC still usually as my premier platform. I will look at that and then in a one-on-one basis with that shared decision making, talk the patient through that there may be other resources out there that look at different information, different research that emphasizes their specific case or their specific situation. Because I think what's happening at the federal level is we are seeing, again, this softening, weakening of recommendations, which is giving more and more people with any type of hesitancy an excuse not to get vaccinated. And we at the, public health level, the patient care level, will experience the increased burden of that. Whether it's navigating a measles outbreak in school or navigating, increased rates of respiratory infections. So yeah. So I'll leave it at that. I hope I answered your question, Ian, but I think some dust is still settling. Jeff, you said there's a new subclade being detected from what is in the vaccine. The change was just detected fairly recently. News already being detected in the U.S. From what is being said, the vaccine is a bit off the mark, not as quite as effective. So yeah, good question, comment, Jeff. And I don't know, you're always welcome to open up your mic to comment a little bit on that. I haven't seen that data coming across, but certainly matching the vaccine to the circulating virus is always a challenge, and the vaccine is moderate at best. Yeah, I think it's still, for me, Jeff, not going to change my recommendations for patients, but I would just let patients know that the vaccine efficacy is not 100%.
Yeah, this was just more to. Whoops, I think I'm muted. Am I
Nope, you're
muted?
good. You're good.
Oh,
You're
okay.
good.
It was a subclade CADE where I think in the vaccine they were looking at, I think it was a J or something like that. And the detection just came after they already started the vaccine manufacturing part, because it was like South America and those places where they did the decision based on what they were seeing. And then it's like back in New York and places like that, they're already seeing this new K. And so the vaccine's just not quite as effective. It's not a piece that would change being vaccinated. I mean, I agree with you on that, but it's that academic piece that, yeah, since influenza changes a lot and, lo and behold, it's just an unfortunate timing. Otherwise, we probably would have had a good match.
Yeah. Yeah, for sure.
So it's just more of just a heads up bit of information.
Yeah.
For
it's
what's
good to
being
know.
seen. So.
Yeah. All right. Well, I know everybody sort of has to get going. We're at the hour. Nnamdi, I'll turn it back to you for any closing remarks.
Can you quickly answer these questions one had during the registration? You said, is the recommendation for RSV going to go back down to 65? And is there going to be an annual dose? Dave, you muted.
Yeah, the second part of that question, no, I don't see anytime soon being an annual dose. And I would imagine we would see a fluctuation in the age, but not probably in the immediate future. I think that ongoing research is looking at the benefit in younger individuals based on the most recent ACIP recommendations that we saw from September.
All right. Thank you very much, Dave, for that awesome presentation. And thanks to all our participants, all our guests for making our time to join us. We'll then send out the slides and the link to the recording very soon to you all. Thank you very much and have a good rest of your day.